You're welcome to Initiative for Health Accountability and Transparency CPD Academy course on Fundamentals of Health Insurance. We'll be looking at the concept and design elements. CPD Academy is a learning hub for all health professionals. My name is Adedoyin Adeyemi and I'll be your instructor for this presentation. The materials for this course include the following. There will be a graded pre-test quiz that all participants must take to assess their knowledge of the concept of health insurance. There is also a video presentation and downloadable PowerPoint presentation which provides more details on this course. At the end of the course, you are expected to take a graded course completion examination. Also, there are suggested resources on the fundamentals of health insurance for further review. However, those who choose to have a course completion certificate and/or CME credit will need to achieve 75% pass and pay a little fee. This is the presentation outline that will follow in the course of this course. There will be a brief introduction, then we'll look at the basic concepts and some important considerations on the design elements, which include feasibility of health insurance, the choice of financing mechanism, population coverage, benefit coverage, provider selection and payment, organizational structure, operationalizing health insurance, and monitoring and evaluation of the health insurance scheme. Afterwards, we'll draw a conclusion. At the end of this course, we expect that every participant will be able to understand the health insurance concepts, explain the design elements, understand some important considerations on the elements, and should be able to design a health insurance program. As a way of introduction, we know that many countries have subscribed to universal health coverage and committed to ensuring equitable access to quality health services for their citizens. Also, health insurance is the most significant financing mechanism for improving access to health services, as well as to provide financial risk protection. Globally, several countries are spending scarce time, money, and effort on health insurance initiatives. However, in resource-constrained environments, many health insurance schemes, both in the public and private sector, cover only a small proportion of the population, with the poor less likely to be covered. Therefore, policymakers and health managers that are involved in developing and scaling up of health insurance must be familiar with how to 1. Increase financing capacity. They must also be familiar with how to extend health insurance coverage to the hard-to-reach populations. They must be able to expand benefit packages and improve the performance of existing schemes. Let's take a quick brainstorming session on the design of health insurance. Please take a few seconds and note down in keywords some fundamental concepts in the design of health insurance that you know. There are basically 8 elements which constitute the fundamental or the building blocks of health insurance, and this must be clearly understood and applied in the designing of the health insurance schemes. They include feasibility of insurance design and implementation, choice of financing mechanisms, population coverage, benefits package, engagement, selection, and contracting of healthcare providers for health insurance, organizational structure, operationalizing health insurance, and the last but not the least is monitoring and evaluation of the health insurance schemes. So this constitutes the 8 design elements of health insurance schemes. This is a pictorial representation of the elements. Overarching as the roof is the feasibility of the insurance design and implementation. It is important to assess the feasibility or possibility of the design as it cuts across all the other elements to know whether they are implementable or not. Also at the base is the monitoring and evaluation. All the elements need to be monitored and evaluated at their different stages of design and implementation. Let's take a feedback on the brainstorming session we had earlier. Did you correctly note down any of the keywords or phrases that constitute the fundamental concepts in the design of health insurance? You still have opportunity to go back to the slides to learn more. Now we'll be looking at the elements one after the other. The first one is feasibility of health insurance. And basically, we'll be looking at 6 important considerations under these elements. The first is to assess feasibility. The introduction of insurance involves multiple government ministries, agencies, and departments. It also involves healthcare providers, consumers, employers, and donors. Policymakers and technical experts must work together to ensure that decision-making is based on facts and technical analysis, and that it involves all the stakeholders and interest groups. In assessing feasibility of health insurance, policymakers must understand and be able to articulate the following. How will insurance contribute to the overall national objectives? How will insurance combat poverty and contribute to great equity? Who are the major stakeholders and what are their positions on health insurance development or scale-up? What are potential political obstacles? What are the possible mitigation strategies? How can a political coalition be built that will be able to push health insurance reforms and successfully keep them on the political agenda? So we'll be taking the second consideration under feasibility of health insurance, and that is to build a political consensus. Political mapping can help understand what level of political support exists for different aspects of health insurance design and implementation. It can help identify where support already exists, where it is lacking, and what strategies may be necessary to build consensus. The third consideration is to assess financial capacity. Financial capacity for funding health insurance is a function of 1. The current and expected economic status, the current level of household health expenditures, some of which might be tapped to finance health insurance. It's also a function of the country's organizational and operational capacity to collect, pool, and spend funds efficiently and effectively. Ministries of Finance and Health must work together to determine the government's capacity and commitment to financing health insurance. Economists, actuaries, and accountants can inform this process. Sociocultural factors and national solidarity is another important consideration. The feasibility of a particular health insurance design will be affected by ethical, behavioral, and sociocultural dimensions. Community-based health insurance is more likely to be feasible where ethnic or geographic groups demonstrate high social cohesion. Cultural norms can strongly affect the ultimate success of an insurance program. In some societies, people believe that planning for a bad situation, such as ill health, may bring bad luck. The fifth consideration is service availability, quality, and provider capacity. These affect feasibility at 2 levels: the physical presence of health workers and facilities and their capacity to deliver quality services. The second level is the provider's willingness to participate in the insurance program. Providers may not be willing to participate if the insurance payments are perceived as too low. Organizational structure and operations is another important consideration. We'll be looking out for existing policies for the insurance scheme regarding financing and population coverage. Also, considerations will be given to institutional arrangements for managing the health insurance scheme, such as defining details like the benefit package, quality standards for providers, beneficiary eligibility, and so on. Existing operational capacity to execute a variety of different technical functions, including actuarial analysis, marketing and communications, enrollment, membership management, collection of funds, claims administration, quality assurance, and financial management. All this will be put into consideration when assessing the feasibility of an health insurance program. Let's take another brainstorming session. This time around, it's on financing mechanism. Please take a few seconds and note down in keywords ways in which you think health insurance can contribute to equity. This brings us to the second design element of the health insurance program, and this is on the choice of financing mechanisms. So we'll be looking at three important considerations. The first is what financing mechanism is feasible. Low-income countries face severe constraints to raising revenues to finance health in general and health insurance specifically. Financing is limited by a high dependency ratio, which is common in settings with high fertility rates that lead to high level of dependence. More dependents, that is children and elderly, cost more than they contribute compared to the working age population, who typically contribute more than they cost. Financing is also limited by the size of the formal sector economy, from which taxes and payroll contributions can be collected. Generating health financing tends to be easier in more urbanized settings where higher population density facilitates registration and revenue collection. So the second point we'll be looking at is what are the health financing objectives? When designing a health insurance system, it is critical that policymakers ensure that health insurance is aligned with the broader health system and health financing objectives. As suggested in the World Health Organization's World Health Report of 2000, health financing objectives might include the following: promoting universal protection against financial risk of ill health. Another objective is promoting more equitable financing of health services. That is, the contributions are based on ability to pay. The third objective is promoting equitable use and provision of services relative to need. That is, access to services should be based on need and not the ability to pay. The fourth health financing objective is to promote quality and efficiency in service delivery. Another objective is to improve transparency and accountability. The last but not the least health financing objective we'll be looking at is improving efficiency in the administration of the health financing system. The last but not the least consideration under the choice of financing mechanism is how can financing of health insurance be pro-poor? How can it favor the poor people? Heavy dependence on out-of-pocket payment is strongly correlated with lack of financial protection and households experiencing catastrophic health expenditure. It is therefore important to consider how revenue generation, pooling, and purchasing in health insurance can contribute to equity. These are basically three ways in which health insurance can be pro-poor. For revenue generation, it is important to consider 1. Imposing progressive general taxes, that is, the rich pay higher income or property tax rates, and there should be no consumption tax on staples such as food. Also, there can be consideration of imposing special taxes for health, that is, taxes on luxury goods like designer wares, designer accessories, luxury vacations, and so on. Another thing to note under revenue generation is that there should be exemptions of poor population from user fees or co-payments. There should be contributions based on income, and premiums should be subsidized for the poor. Also, external donor funds can be solicited to subsidize premiums for the poor. Under pooling, there should be establishment of a compulsory universal coverage so that the rich cannot opt out of the risk pool. There should be consideration of risk redistribution among multiple fund pools. Example, the richer districts subsidizing poor districts. For purchasing, we should exclude high-end, expensive elective care from the benefit package. We should ensure an adequate supply of health providers and facilities where the poor live. You should establish incentives for providers to serve poor populations. Also, there can be provision of vouchers or other incentives for the poor to encourage them to use priority services. We can shift financing away from inefficient delivery, example from hospitals with low occupancy. Let's quickly take the feedback on the last brainstorming session we had. Did you correctly note down any of the ways in which health insurance can contribute to equity? If you did, well done. But if not, you can always go back to the slides to look at them again. Now we'll be going to the third design element, which is on population coverage. We have basically two important considerations to look at. The first is to achieve universal coverage. Under WHO Resolution World Health Assembly 58.33, universal coverage incorporates two complementary dimensions in addition to financial risk protection. These dimensions include 1. The extent of population coverage. Who are the people covered? Who is covered? And secondly, the extent of health service coverage, that is the benefits covered. Health insurance population coverage should not be selective to easier population group only, such as those that are employed in the formal sector, whether public or private. Attempts should be made to ensure that the informal sector and the hard-to-reach populations are adequately targeted for coverage. The second consideration is expanding insurance coverage to the hard-to-reach population groups. In order to ensure equity, health insurance should be designed to reach the poor and marginalized populations. Due consideration should be given to factors and characteristics that facilitate or hinder population coverage. Incremental approach to expanding population coverage is likely to be the most politically and financially feasible. This takes us to the fourth element, which is on benefit package and cost containment. We have 5 considerations to look at. The first is to look at what is in the benefit package. The second will be to look at the criteria that should guide the design of the benefit package. The third will be looking at the benefits that the insurance scheme should cover. While the fourth consideration looks at benefit packages and financial sustainability. The last consideration is how the cost of the benefit package can be contained. Now specifically, what is in the benefit package? As a way of definition, the benefit package is usually a list of general categories of care. Could be outpatient care or inpatient hospital care, with details regarding the level of coverage in each category. The details can include the type of provider, specific services or conditions that are covered or excluded, the limits on services, example number of days that can be spent in the hospital, and if there are any co-payments or deductibles. Now we'll be going to look at the criteria that should guide design of the benefit package. Basically, 4 criteria should be considered in choosing essential health interventions to be included in the benefit package. 1. They should be technically efficacious and can be delivered successfully. Secondly, the targeted diseases should impose a heavy burden on society. Thirdly, the social benefits should exceed the cost of the interventions. And lastly, the needs of the poor should be stressed when choosing the benefit packages. We'll be looking at what benefits the insurance scheme should cover. Given limited resources, services to be included in the benefit package should be those that are likely to 1. Improve population health outcomes. And these outcomes will be based on the burden of disease, the demographics, mortality and morbidity rates, and epidemiological trends. Also, the benefit package should be those that are likely to protect households from catastrophic health expenditures. The services should also include those that have high volume and low cost services that have a high potential for health impact. Examples of such services are family planning, treatment of upper respiratory tract infections, and infectious diseases. Lastly, but not the least, the services to be included in the benefit package should be public goods that have large social benefits, such as immunization. Let's look at benefit packages and financial sustainability. We'll be looking at this consideration under 2 points. The first point is the financial consideration. Selecting an appropriate benefit package requires financial analysis to analyze the target population's current pattern of out-of-pocket health expenditure. Also, there is the need to balance coverage for the most financially burdensome services and the services with the greatest health impact. Health actuaries can help estimate the cost of the proposed health benefit package to determine if sufficient resources exist to finance the package. For political considerations, political acceptability is of key importance in designing the benefit package, especially among the people who are paying for the insurance scheme. If beneficiaries are expected to pay the premium, they must understand the concept of insurance and find the benefit package to be worth their payment. If the government will fund a mandatory insurance scheme through general tax revenues, the design of the health benefit package must align with the national health goals. Now we'll be looking at how the cost of the benefit package can be contained. The goal of cost containment is to make the insurance scheme solvent and financially self-sustaining. Cost containment methods can discourage unnecessary wasteful spending so that there are more funds for needed healthcare services. So we'll be looking at some ways in which cost of the benefit package can be contained. Many health insurance plans control cost through deductibles and co-payments, as this mechanism control the tendency to overuse health services. Some schemes also set a ceiling on the benefits an individual may pay for within a given time frame, such as a year. Example, for an optometric case, maybe the person has been prescribed to use glasses. So now the benefit package is such that for every pair of glasses that's been prescribed, the amount is 15,000 that the insurance scheme covers. But you now want a designer frame or a customized lens like a photochromic lens, which will definitely cost more than 15,000. The patient or the enrollee will now pay any cost that is above the ceiling that has been set by the scheme. And also for such prescription, you are entitled, they also put some time limit. Maybe you can only get glasses maybe once in 2 years. So if after 3 months the glass gets broken or stolen or something, the enrollee bears the cost of replacement. Other ways in which costs can be contained include covering only generic drugs or use of the essential drug list, and excluding expensive services such as organ transplants and dialysis from the benefit package. Mandatory enrollment and eligibility policy that diversify risk and combat adverse selection is another method of cost containment. For example, this may mean requiring that the whole family enroll and not just the sick and the elderly people. Other cost containment methods include introducing waiting periods for beneficiaries to use certain benefits and to prevent people from enrolling just after diagnosis or when a service is needed. For example, when a couple just get married, naturally the next stage is to have children, and they now decide to buy an insurance plan for the purpose of this. Most insurance companies introduce a waiting period of like 12 months. During these 12 months, the wife cannot access antenatal care until after 1 year. They can access other services, so that is another way to contain cost of the benefit package. Provider selection and payment methods that reward quality and efficiency is also a way to contain the cost of the benefit package. Assigning a gatekeeper responsible for authorizing the insured person's access to specialized tests and services that are covered by the insurance scheme is also a way. Effective communication among stakeholders such as the insurer, beneficiaries, and providers, so that they understand their roles and responsibilities, their rights under the scheme, and ways to collaborate to avoid wasteful spending. There's also need to control fraud or abuse by either the beneficiary, the provider, or both. Promoting the use of protocols or clinical guidelines among providers to standardize service delivery for certain diagnoses or types of care to contain costs and to improve quality. Lastly, case management of chronic diseases to promote health and avoid inpatient admissions is also a way to contain the cost of the benefit package. Let's take a third brainstorming session, which will be on provider selection and payment. Please take a few seconds and note down in keywords some important considerations on provider selection and payment in the health insurance design. These are some of the considerations we'll be looking at under this element, which is the fifth element of the design of health insurance scheme. The first point to look at is the provider selection and payment. Choosing service providers would require a clear understanding of the policy goals of a health insurance scheme. You have to understand access, quality, revenue, efficiency, administrative simplicity. All this should be put into consideration when choosing service providers. In selecting the provider payment method or methods, attention should be paid to creating incentives that are consistent with scheme goals. Provider selection is an important design issue for health insurance because provider behavior is a major determinant of beneficiary satisfaction as well as medical costs. It should begin by reviewing the current market structure among health service providers, especially in relation to the target population and the benefit package. Issues to be considered include: where are people going for services? Are they going to the public or private facilities? What are the cost and quality differences for service provision in the public versus the private sector? What is the geographic distribution of providers? Are they more of public or private? What is the population's perception of public and private providers? After this, the policymakers should review the following information on providers to determine if the benefit package is feasible, and also to decide how to select providers to maximize access by target beneficiaries. They should also review the information on providers to determine how to pay the providers and how providers at different levels will be linked. That is the referral system. They should also be able to identify possible efficiencies that can be realized through better provider payments. The information to be reviewed include: how are providers organized? Are they individual practitioners? Are they a network of providers? Are they institutional providers and referral systems? Where are they located, especially relative to target populations? What are the main types of health facility ownership? Are they public, religious, not governmental organization, private for profit, or cooperative? What are the most common types and sizes of facilities? Is it a single private practice? Is it a group practice? Is it a network of facilities? Is it a clinic or hospital? At what level of care do different types of service providers operate? Is it at the primary, secondary, or tertiary level? The other information to be reviewed include: to what degree are services integrated? Is it single services, general healthcare services, vertical programs? What is the reputation of different healthcare providers? How are they perceived by consumers? How well do different service providers manage health services? What is the quality of service provision? And how efficient are different providers? Provider choice is another important consideration when selecting healthcare providers. In areas where there is a mix of providers, a key insurance scheme design decision will be the degree of freedom that beneficiaries will be given to choose their provider. Can they go to a private provider? Can they go directly to a hospital or specialist? Or do they need to be referred by a primary care physician? This issue affects beneficiary satisfaction, as people prefer to choose their doctor, and it also affects medical costs. People tend to choose more expensive levels of care if they are not paying for it directly. Greater provider choice may be possible if the insurer can contract private providers and contain costs. To encourage beneficiaries to use primary health care, many insurers require primary care providers to serve as gatekeepers who determine the medical necessity for referral to hospitals and specialists. Shortages of health workers and facilities present a difficult challenge. Healthcare providers may not be available in all geographic areas or may be disproportionately located in urban areas with very few, if any, in rural areas. Provider quality is also an important consideration. Health insurance can offer a powerful means of improving quality by linking provider payments to quality standards and outputs. There are different ways to ensure provider quality, and these include accreditation of providers. This is to ensure that eligible providers participate in the insurance scheme. Quality standards should be developed for participation in the insurance program. Another way to ensure quality is complaint management. That is, addressing complaints by beneficiaries regarding provider quality. Clinical guidelines or continuing education is also a way in which to ensure provider quality. This requires that health workers comply with clinical guidelines or continuing education in the care of their patients. Now let's look at provider payment methods. Payment methods are one of the most sensitive issues for health workers and facilities, since payments directly affect their economic interests. There are many different methods and they can be used in combination. Below is a summary of characteristics of some provider payment methods. One of the payment methods is the fee for service. This is a per service item unit of payment. That means payment is made per service. The financial risk to providers is very low, but it is very high to the payer. The providers tend to over-provide when it comes to this provider payment method, since they know they will be paid for every service they render. The quality of service also tends to be of high quality because the providers also know that they will be paid, but the cost control is very low. The administrative complexity is medium. It's not too complex and it's not too simple. Capitation payment is another method. The unit of payment is per patient. This mode of payment is paid per head. The financial risk to providers is very high, while the risk to the payer is low. The providers tend to under-provide because they know the services they are rendering is not going to be billed individually. The payment is being made for the patient as a whole, so they tend to under-provide services. Quality of the services may also be sacrificed to contain their financial risk. The cost control is very high, and the administrative complexity is also medium. We have a third payment method, which is the results-based payment. The unit of payment is a verified achievement of predetermined targets, and the financial risk to providers is very high. These result-based payments can be combined with any of the methods that have been listed above to reward achievement of measurable targets. However, it's very complex administrative-wise. The result-based payment is also known as the pay-for-performance payment and result-based financing, and it explicitly links an incentive payment to the achievement of a predetermined result or output. Let's look at provider contracts. An insurer may choose to contract out service provision for many reasons, such as to focus on its role as a purchaser and outsource service delivery, to allow beneficiaries to choose private providers, or to engage desired providers in specific locations or for specific services. Contracts are the written terms and conditions of the agreement between the insurer and the provider to clearly define the services that are covered, the price or rate to be paid, the payment method, minimum quality, and performance incentives for efficiency and quality, and also administrative procedures like the forms and billing cycles. Now let's look at operational and information constraints. In engaging providers and choosing a provider payment method, it is important for policymakers to consider the extent to which valid information is available on medical costs, utilization rates, case mix, and population and provider characteristics. Other important considerations include the technical capacity of both the insurance entity, that is the payer, and the providers to use new tools, to enforce and comply with new procedures, and collect accurate data. Finally, to be affordable, payment and administration systems must have reasonable transaction costs and offer value for money. Now, a feedback of the third brainstorming session we had earlier. Did you correctly note down any important consideration on provider selection and payment in health insurance design? As you already know, The slides are available for further review. Now to the sixth element of the design, which is looking at the organizational structure. Four important considerations will be discussed under this element. The first is to look at the principles for the organizational structure of health insurance, to look at the critical functions for health insurance, the organizational structure and size, and the governance within the organizational structure. For the principles for the organizational structure of health insurance, this element deals with the following questions. What is the institutional arrangement? Who is going to do all this work? What checks and balances can be established to ensure that the health insurance achieves its policy goals and funds are protected from misuse? An ideal organizational structure should be fashioned based on two guiding principles. The first is building on existing organizations as opposed to creating entirely new ones for insurance administration. Effort should be made to look for existing capacity and competencies and build on it. The second principle is to build accountability into the organizational structure and hold entities accountable for effective execution of their roles through control mechanisms such as regulation, checks and balances, clearly defined management functions, and clear and enforceable contracts. The second consideration under the organizational structure is to look at the critical functions for health insurance. Health insurance agencies perform several functions or tasks which remain constant across different types of insurance schemes, from the small community-based health insurance schemes to the national programs. The critical functions include policy and regulatory functions, provider management functions, financial management functions, beneficiary communications / marketing, enrollment and revenue collection functions, and lastly, monitoring and information system functions. Now we'll be looking at these functions in details, one after the other. The policy and regulatory functions include designing the scheme, and this includes the financing methods, eligibility criteria, and the benefit package. The function also identifies which body, ministry, department or agent, or community organization that will manage the scheme. It also sets quality standards for providers. The policy and regulatory functions also includes setting standards for communications with beneficiaries and establishing financial regulations to ensure solvency and to protect consumers. Now, who carries out the policy and regulatory functions? Basically, in the public sector insurance, it is the legislative and executive branches of the government that work together to set broad policies for the insurance schemes regarding financing, population coverage, and management. While in the private sector insurance, a regulatory body can be established by law that enforces regulations to ensure solvency and protect consumers. For the community-based health insurance scheme, a network or non-governmental organization can provide technical assistance and management services or arrange for reinsurance to support the growth and sustainability of mutual health insurance schemes. The provider management functions include selecting providers, promoting quality through payment mechanisms, provider accreditation, quality audits, negotiating with providers and other entities, including negotiation of the payment system, managing compliance with parameters that are set forth in the contract and budgets, processing medical claims, including checking for compliance with fee schedules and benefit regulations, ensuring that patients are entitled to the benefits they are claiming, and to prevent fraud and control costs through other steps. Also, it's also important to make sure that providers are paid on time according to the agreed payment basis. Now, who carries out the provider management function? In Nigeria, it is basically the National Health Insurance Scheme, State Social Health Insurance Scheme, the third-party administrator, which include the Health Maintenance Organization, that is the HMOs. The financial management functions, in addition to provider payments, include financial management and planning to ensure solvency, including cash management to ensure providers are paid on time and interest is earned on any cash balance. It also includes performing actuarial analysis to anticipate and avoid potential budget deficits by taking preventive actions such as raising premiums, reducing benefits, controlling costs, or revising reinsurance coverage. Other financial management functions include ensuring accurate, transparent financial reporting to all stakeholders, including an annual audit by an independent accounting firm. Applying, if needed, risk adjustment across multiple insurance funds is also a financial management function. Now, who carries out this financial management function? The National Health Insurance Scheme, the State Social Health Insurance Scheme, and the third-party administrator, which includes the HMOs. For the beneficiary communication / marketing, enrollment, and revenue collection functions, these include educating the public about the insurance scheme, generating demand for enrolling, reaching out to special populations, educating members about entitlement to benefits, enrolling eligible beneficiaries, collecting premium payments or taxes, reviewing and redressing grievances, and ensuring that employers register their employees and deduct contributions properly. Who carries out this function? They include the National Health Insurance Scheme, the State Social Health Insurance Scheme, the third-party administrator, including the HMOs, non-governmental organizations, the community, or the civil society organizations. The monitoring and information system functions include designing and running information systems and using the information in business operations, such as provider, financial, and customer management, and so on. It also includes capturing data from providers on service use, diagnosis, practice patterns, and clinical outcomes. The other functions include data analysis and using information for management decisions to improve quality, equity, and efficiency. Developing systems to support cost control and quality assurance, and monitoring compliance by providers and beneficiaries with rules for referrals, co-payments, waiting periods, and case management is another function under the monitoring and information system. Other functions apart from the critical functions for health insurance include personnel administration, training, and staff development and organization. Also, acquisition, management, and maintenance of building and equipment that support insurance administration is also another function. Now let's look at organizational structure and size. Please note that organizational structures vary across schemes. This is like a structure for health insurance in Nigeria. The government is the main overseer of the health insurance company, and it is responsible for monitoring and evaluating the overall scheme and regulation. As we can see, the government, which can be the National Health Insurance Scheme or the State Social Health Insurance Scheme, is at the top of the structure, and they are involved in regulation, contract management, monitoring, and evaluation. While the insurance company interacts directly with providers and consumers, the insurance company can also be represented by the HMOs, and they do claims processing, provider network, pre-authorization, enrollment, enrollee sensitization, and some other functions. The government funding is given to the HMOs for premium subsidies for enrollees, while the insurance company is meant to feed the government back with reports on claims, utilization, and financing data. So the insurance company interacts directly with the healthcare providers, as we can see, and the enrollees from this structure. They interact with the providers through claims payments. They pay their bills, and they make sure they give them the provider empowerment. That is like the list of enrollees that are registered with each healthcare provider, while the provider has the function of reporting back to the HMO with like utilization data reports, and also they need to submit their claims to the insurance company for payment. The insurance company services to the enrollees include education, sensitization of their rights and benefits, and even enrollment of new beneficiaries, upgrade of existing ones. While the enrollees have the function of paying their premium to the insurance company and submitting their membership contributions to them. The interaction between the healthcare providers and the enrollees occur, for example, during service provision and also during co-payments, if the service to be rendered has some deductibles that the enrollee needs to pay. So basically, this is the simple structure for an health insurance scheme. Governance within the organizational structure is an important consideration under the organizational structure. Without good governance, efforts to expand health insurance could waste resources, destroy public trust, and fail to achieve policy objectives. Governance of health insurance can be defined as accountable and transparent relationships between health insurance stakeholders such as the government, the beneficiaries, the payers, the healthcare providers, and other insurers. Good governance within an insurance scheme can be achieved in different ways. The first is a coherent decision-making structure. Decision makers are empowered with the authority, tools, and resources to fulfill their responsibilities and face consequences for their decisions. A second way to achieve good governance is stakeholder participation. Stakeholder input should be incorporated into decision making and oversight. There should be transparency and information. Information should be accessible to decision makers and to the stakeholders who can hold decision makers accountable. Supervision and regulation is another way to achieve good governance. Actors must be accountable for their actions and performance. This type of accountability involves consequences for poor performance. Every poor performance should be sanctioned and penalized. Another way to achieve good governance is consistency and stability. An insurance scheme that is a stable institution behaving consistently helps avoid uncertainty around rulemaking and processes over time, and the potential disruptions of political change is reduced. This encourages longer-term investments by providers and greater uptake by consumers. We have come to the seventh element in the design of the health insurance scheme, and this is operationalizing health insurance. Operational systems refer to the administrative and management systems, functions, and processes that support the execution of health insurance. These are the considerations we will be looking at. The first is the financial processes and management. Financial management is critical to ensure adequacy of financial resources to cover operating costs, keep the health insurance funds in financial equilibrium, and to ensure transparency for sound monitoring, management, and viability. It also includes maintaining an adequate operating reserve to cover known costs, risks, and unforeseeable short-term risks. The financial management system should have the following three main elements. A budgeting system, which is to plan for and understand all the costs related to the health insurance scheme. An expenditure tracking system to ensure the proper internal controls to manage the flow of funds. And a cost management system to ensure payments and costs are in line with what is budgeted for financial viability. A second important consideration under operationalizing health insurance is to look at the contract management. Sometimes, the entity managing the health insurance program may not have the skills or capacity needed to accommodate all health insurance functions, and may deem it necessary to contract with different actors to fulfill specific functions. Therefore, third-party administrators, that is the TPAs, that have the necessary skills may be contracted to perform some operational functions. Possible contractual relationships will depend on the scheme's organizational structure. The possible functions that can be contracted out include actuarial analysis, claims management and processing, provision of healthcare, grievance redress, risk bearing or reinsurance, beneficiary enrollment and premium collection, and customer service and marketing, that is education to beneficiaries. Regardless of whom the contract is between, effectively written contracts must always specify mechanisms to ensure compliance. Contract language should be laid out not just to identify the functional responsibilities that are being transferred, but to also lay out regulations by which the contractor must abide. This will ensure that other stakeholders, particularly the beneficiaries, are protected. Now let's look at marketing and communication. These two serve many purposes. It can be used to educate the population about the scheme to generate demand for enrolling, that is marketing. It can also be used to educate the beneficiaries about what benefits they are entitled to, the process for using the scheme, and their rights within the scheme. Thirdly, this process ensures that the beneficiaries understand their rights and coverage. Enrollment of beneficiaries is a critical success factor in the implementation of health insurance scheme. The process of enrollment can be administratively expensive, and it requires different strategies for different types of beneficiaries. Prospective clients must be educated about what the health insurance program is, why it benefits them, and why they should enroll. A mechanism must be established for individuals and families to show they are enrolled, such as production of an identification card. Systems must be established to minimize the opportunity for fraud. If the insurance scheme issues an insurance card to demonstrate membership, other operational considerations need to be made. How will the insurance card be linked to any verifiable information about the beneficiary? How do you make sure that that card is unique to that member and cannot be given to another person? Secondly, how will providers monitor and manage their health delivery system with different insurance schemes and therefore the different insurance cards to ensure they get paid accurately? You should also look at how fraud can be minimized and the integrity of the insurance card maintained. How will insurance cards be printed and distributed, particularly in resource-constrained settings? These are just some of the questions that need to be addressed if an insurance card is used to verify membership in an insurance scheme. Now let's look at premium collection, or the financial contributions. Premium collection is the gathering of financial contributions for participation in the health insurance scheme. It is a critical function that can be very difficult to manage in low resource settings. Depending on the insurance model being used, premium contributions can be collected through general taxes, payroll deductions, or directly from individuals enrolling in the scheme. Now let's move on to claims administration. This refers to the process of receiving, reviewing, and adjudicating and paying claims. In many health insurance schemes, the payer is not in a position to manage the claims process, so it is essential that another entity is hired to administer the claims. In our setting, the National Health Insurance Scheme hires the health maintenance organizations to process the claims. In the cashless system, the beneficiary receives a covered service from a provider and does not pay the provider, other than the possible co-payment or for items that the scheme does not cover. The provider submits a claim for that service to the claims administrator for payment. In a reimbursable arrangement, the beneficiary seeks services and pays the provider out of pocket. The beneficiary then submits the receipts and a claim for that payment to the claims administrator for reimbursement. Whichever submission option, the claims administrator must determine if the claim is an eligible expense under the health insurance policy, because this is an area of potential fraudulent behavior. The claims administrator must have very clear guidelines on which claims are allowable. Often, the claims administrator needs to employ physicians or healthcare professionals to determine if a service was medically necessary and to identify mutually exclusive claims. The claims administrator must also investigate any fraudulent claim to ensure that the right claim was submitted and that fraudulent activity did not occur. Obtaining all information is very important in claims investigation. This is necessary to determine the appropriate amount to pay on a given claim. In claims administration, the payer and the provider generally agree upon a rate schedule, which is the set of fees determined by an insurer or payer to be acceptable for a procedure or service, which the physician agrees to and accepts as payment in full. To minimize the number of claims that must be investigated, some insurers require pre-authorization for some services. And this is when the provider must solicit the insurer's authorization before delivering a service to a beneficiary. And this must be done to guarantee payment if no other questions arise. Looking at the information system and monitoring. Please note that monitoring is critical to every design element of the health insurance scheme. Continuous monitoring of insurance scheme performance against planned tasks is a key responsibility of the managing entity, and it must be undertaken routinely throughout the life of the scheme. Key areas for monitoring are both the outcomes, that is the number of individuals that have been enrolled, the utilization rates, the claims ratios, and so on, and the operational processes to ensure that the program is running smoothly. A functioning management information system is necessary for monitoring and eventually evaluating an insurance program. The MIS will consist of a series of tools, procedures, and information flows, and this can either be manual or electronic depending on the technology that is available at the different levels of the scheme. The basic MIS administrative and technical monitoring tools and procedures are as follows. 1. Enrollment and financial contribution data. Coordination of benefits and claims, and financial monitoring. For the enrollment and financial contribution data, a membership database is needed to record information about members and their dependents and the payments they have made. An individual or family membership card should be issued with an identification number, the name, gender, and date of birth of each beneficiary. Other important information such as the beneficiary address, relationship to the household head, and occupation of each beneficiary should be collected and entered in the membership database. Some basic monitoring tools and documents that are used in enrollment monitoring are as follows. Membership card, listing dates of coverage, up-to-date registers of members, up-to-date registers of premium payments, and renewal information. For coordination of benefits and claims, a MIS ensures that claims are paid accurately and in a timely manner as it monitors the claims administration process. It will also be able to produce disaggregated data on utilization and cost by age, gender, membership status, disease, diagnosis, service type, provider type, that can guide management decision making. The basic tools for the claims processing monitoring include the payment procedure, healthcare provider invoice register, claims register, claims listing by provider type, utilization and cost of service monitoring sheet, average claims cost monitoring sheet. For the financial monitoring, generally, health insurance schemes use standard financial management systems and practices such as budgeting, accounting, and payroll systems, cash management, and issuance of auditable financial statements, the income and expenditure statement, and balance sheet. Now, Looking at the last but not the least design element for the health insurance scheme, which is element 8, and it is on monitoring and evaluation of the health insurance schemes. Note that monitoring and evaluation are two complementary but separate functions which often serve distinct purposes. The figure below displays the structure of an M&E system's major components. So basically, this is an health insurance M&E structure. It includes the input, process, output, outcome, impact, and the things that are all considered in the monitoring and evaluation processes, including budgets, marketing, enrollment, service utilization, and the impacts, poverty reduction, and so on. For example, under the input, we can have budgets as some of the things that are as inputs, the staff responsibilities, and the policies, while the process includes marketing, premium collection. The output will be the enrollment rate, the fund collection rate, while the outcome are the health service utilization that we see, the financial burden reduction. The impact will be poverty reduction, health status improvement, and the base will be monitoring and evaluation will be going on all through these processes. And also there will be auditing and annual evaluation. Inputs are the resources put into an activity, and in this case a health insurance scheme, so that it can deliver its planned activities. The inputs include time, money, human resources, and physical infrastructure. Processes are the planned and carefully coordinated activities that are carried out to achieve the outputs and outcomes. Outputs are the tangible results that the activities produce. Outcomes are all the results of the efforts, and they usually directly benefit the consumers. Impacts are the broader, longer-term effects resulting from an activity and generally relate to the overall goals. Health insurance scheme contributes to the impact, but impacts also are affected by other efforts and factors. Impacts can be difficult to assess in the short term. Looking at monitoring proper, it shows us how the health insurance scheme is doing on an ongoing basis by tracking the input and outputs to assess whether the scheme is performing according to plan. A functional MIS is essential to do effective monitoring. It is used on a day-to-day basis and facilitates regular follow-up of activities and finances during implementation. The MIS data can also be used to evaluate the performance of the health insurance scheme by the management team, as well as through internal and external audits. On the other hand, evaluation shows what the scheme has achieved by assessing its outcomes and impacts. It is important for ensuring that the scheme is having its intended effects. Some of the questions that can be asked while assessing evaluation of the insurance scheme are: is it increasing access to health care? Has coverage of health services increased? Are the right beneficiaries being targeted? Have out-of-pocket expenditures reduced? These are some important questions to consider while doing evaluation. Positive evaluation results can increase political buy-in for a scheme as it scales up consumer demand for enrollment, while a negative evaluation result can help policy makers to revise the scheme design or operations so that desired results are achieved. Evaluation results are also important for determining whether the most cost-effective approaches are being used. A number of evaluation approaches can be used to assess health insurance schemes, and they include an experimental evaluation design, a quasi-experimental evaluation design, case control comparison evaluation design, a cross-sectional evaluation design, and a pre-post evaluation design. These approaches will be discussed in our subsequent courses. Let's look at the key indicators for monitoring and evaluation. They can be classified into 3 categories: management performance, financial performance, and impact. The insurance scheme management should develop performance indicators that suit their needs. The management performance indicators provide information on the vitality of the scheme, while the financial indicators are used to evaluate the ability of the insurance scheme to rely on its income to cover expenses over a long term. Evaluating impacts of a health insurance scheme in terms of equity, efficiency, and effectiveness requires the use of analytical methodology that cannot be fully summarized in this presentation. Please note that public satisfaction is another important dimension. In conclusion, we've seen that health insurance is considered as the major financing mechanism to achieve universal health coverage. Many countries that subscribe to UHC have committed to ensuring equitable access to quality health services for their citizens. Globally, several countries are spending scarce time, money, and effort on health insurance initiatives. However, in resource-constrained environments, many of these schemes, both public and private, cover only a small proportion of the population, with the poor less likely to be covered. Therefore, policymakers and health managers that are involved in developing and scaling up of health insurance must be familiar with how to increase financing capacity, how to extend health insurance coverage to the hard-to-reach population, how to expand benefit packages, and improve the performance of existing schemes. Please, these are some suggested resources for further reading on health insurance design. We'll be closing with this quote from Jan Schakowsky, a US legislator, which says, "Without health insurance, getting sick or injured could mean going bankrupt, going without needed care, or even dying needlessly." In closing, note that health insurance should be a given for every citizen. We have come to the end of this course, and I hope that we have been able to achieve some, if not all, of the objectives that were listed at the beginning of the presentation. Please do well to download the full PowerPoint presentation for review on the fundamentals of health insurance. Thank you.